Welcome to the Research Works podcast, brought to you in association with the Healthy Strides Foundation. Your hosts are Dr. Dana Poole
and Dr. Ashley Thornton, and we're here at the AusACPDM conference in Cairns, Australia, to interview world-leading researchers, clinicians, and people with lived experience
to support your practice in being more evidence-based.
We are back for another exciting episode of our AusACPDM conference series. This time, we are joined by Dinh, who is a physiotherapist at the Healthy Strides Foundation. Hi, Jordan.
Hello.
Hello. Thanks for having me.
Thank you for coming on. We are really excited to talk to you about your poster today, which is titled Walking Endurance with a Supportive Stepping Device in Children and Young Adults with Cerebral Palsy, a Clinical Audit.
Good words.
Yeah.
I feel like you can judge a lot by a title. So there's a lot in a title, really, isn't there?
It's a real skill putting together a title that kind of contextualizes your study.
Yeah, right.
Yeah.
Within the word limit of how many words you're allowed for a title.
There's always a tricky word
That
limit.
is really tricky.
That's one thing that people might not be aware of.
Yes, that's true. Yes.
Most of the time you start off with a very elaborate title that you then have to become very concise with because there is a word limit.
It's true. Or the alternative, as you submit in for a journal, they'll go, actually, there's not enough words in here.
Yes.
And then you have these epically long ones. But this one, Jordan, I feel like is a really good one because it already speaks to the themes and things that I suppose is the direction of your clinical work, in terms of the supported stepping device and walking endurance. So let's start from the beginning in terms of why you wanted to do this work. Why was this important?
Great question. Great question. I think, that's a big question to think about. But what we do at Healthy Strides just really encapsulates that in the title itself. In the 20-odd words or less, it was all about getting kids up in a supportive stepping device and seeing what they can do. I think this poster and the work behind it really captures in terms of what we can actually do with kids and how we can actually get them up and what that leads to.
And why is that so unique still? Because I feel like, we do talk a lot about walking endurance and fitness, but, why did you have to even do a clinical audit here in the first place? I think let's go there.
Yeah, I think, when you look out in what's out there in terms of the information and how kids that have more physical limitations, GMFCS 4s and 5s get up, there's not much out there in terms of what they can actually achieve and what interventions actually influence their capacity to walk.
Yeah.
That was a burning question I think a lot of us had, and clinical audit really much so answers a lot of those, some of those questions, but inspires more questions in terms of what's next as well.
Yeah. I love a clinical audit. And I don't, we probably don't talk about clinical audits a lot on the podcast in relation to some of the other methodologies that are out there. Can you explain a little bit more about what a clinical audit involves?
Well, for the clinical audit that we did with the interventions that we did at Healthy Strides, it was a big blanket over all the time points that we set for the 6-minute walk test, starting back from 2019 through to 2023. So a 4-year span.
Wow.
There was 827 to be exact
time
points of 6-minute walk test. But the ones that actually made the most, or that we included in the clinical audit, came down to 324 or 177 in comparisons, pre and post, specifically for cerebral palsy.
Yeah.
Being specific in that let us actually decipher and see what improvements were actually capable.
Right.
Yeah.
So the population was cerebral palsy for this one.
Indeed.
And what was the intervention?
The intervention was community-based intensive therapy programs, primarily focusing on locomotor training.
Right.
So a combination of treadmill training and overground walking for kids with cerebral palsy.
Okay, so quite a set protocol almost, like in terms of the power of going doing a clinical audit is sometimes the messiness. I mean, you and I have both done these before. Yes. There's the messiness of the data sometimes because it's real life. It's clinical
data. It's not research data.
That's right. So you might have those missing time points from time to time. It's different to collecting for a research study.
Yeah.
But this still seems like you've got a lot of data. And in addition to that, it's quite a specific intervention. So you can almost already define your intervention. I mean, let's think about the PICO, right? We've satisfied all those requirements already. So it's quite a clean clinical audit from what I can tell?
Absolutely.
Yeah, I agree. It was it can be messy at times, but I think it was messy clean. We normally take assessments pre and post, so it was easy to establish pre and post intervention.
Yeah, that process is already in place.
Yeah, it was already in place. So it was just a matter of actually looking through the data.
Yeah.
So that was a messy part, but it was clean because it was easy to look through.
Yeah, sure.
And just coming back to your population, Jordan, we talked about obviously children with cerebral palsy. Were you focused on any particular GMFCS level, or were you looking at all children with cerebral palsy who are accessing these interventions?
All children, yeah. So it's all the way from GMFCS level 1s and 2s for the ambulant children with cerebral palsy through to GMFCS 4s and 5s with greater physical limitations. And we did also look at all the kids, regardless of age, that came through Healthy Stride. So from 13 months through to 24 years of age.
Wow, it's a huge span.
Yeah.
But I feel like the question that always comes from that is 6-minute walk test and GMFCS level 4 and 5. Tell me about that. Why?
Yeah, so that was the most surprising improvements. We saw improvements with GMFCS 1s and 2s and 3s.
Which you'd expect,
which
hopefully.
Exactly, which you'd expect after an intervention. But 4s and 5s, which isn't routinely, firstly assessed, but then reported on, we found surprising improvements. There was clinical and statistical significant improvements for both of those groups.
Wow.
I mean, when I look at your abstract and I look at the changes in numbers, we always say let's not go into too much stats when we're here, but I feel like the GMFCS level 4 and 5, number one, finding the right kind of intervention is really tricky.
Yes.
How many times have we spoken about that?
Yeah.
Right. And then to see the changes. So GMFCS level 4, they made changes of, 42 meters and 15.3 meters pre and post. So 15.3 for GMFCS level 5.
Yeah. It's pretty incredible.
Right.
Yeah.
What does this mean clinically? Why are these important findings?
15.3 meters is one side of the room to the other side of the room. It's as easy as that. I think for children that are typically in a wheelchair most of the day, being able to get into a walking frame or supportive stepping device and moving themselves from one side of the room to the other side, it's small for most of the ambulant children, but huge for those guys that don't typically get up and get to move. I think there's huge health benefits as well with getting up, as we know.
Yeah. And just that perspective change, I think, as well, which we've talked about before. You know, you're seeing the world differently and being able to experience the world from a different perspective is really powerful as well, isn't it?
100%. Yeah, I think the kids that did get up as well, the autonomy and their willingness to move, we also found changes as well. But I think they just loved to get up, and the enjoyment in their faces and their parents' faces as well was priceless.
Yeah. I think the other really important thing about this clinical audit and clinical audits in general is that you are providing information about a population that, as you mentioned before, don't typically get to be involved in a lot of the RCTs and other types of studies because, you know, it's really tricky to kind of do that within the rigor of a clinical trial sometimes. I mean, we've talked a lot on the podcast about how to navigate that issue, but I think what this clinical audit highlights is, you know, really the benefits for those non-ambulant children.
And that's such a good perspective. I love how you put that. And when you think about, therefore, what is actually happening already in the community and what's possible, because knowledge translation is always a big factor, right? So you do a clinical study and you have to make sure there's rigor. For 100% you do. But when you don't include these kids in the study, you do kind of get left with, well, what can I do? And what improvements could I possibly even expect? So when we're having conversations with families, we can go, we can show you can make this improvements, and it shifts the conversation significantly. So a clinical audit in this case was very useful. So I want to talk a little bit more about supported stepping device and what that actually looked like. So was there any helping them to push along? Was there any facilitation? What happened for these tests that made these changes, I guess, is useful, because that's not a common picture to see a supported stepping device.
Yeah.
Yeah.
These
Well,
tests.
that's it. Like, I think a lot of the kids that have greater physical limitations don't typically get up in a supportive stepping device. But regardless of brand or the child's needs, it was all about positioning them in a safe way to let them move and to let them walk. I think we kept it standardized. So pre-assessments, whatever was done, whether they needed support after 30 seconds was done also at post.
Right.
But most of the time, their ability to step and propel a walker improved. So that was also reported on as well, and how much help they actually needed.
AFOs, no AFOs?
Yeah, all of it was captured. AFOs, no AFOs, again, standardized between pre and post assessment. So for those that weren't wearing AFOs at pre, but then got AFOs during, we still assessed them without AFOs.
Okay. Yeah. And in terms of the kind of supports, like you said, if they're positioned safely and optimally, what are some of the things to look out for positioning? Like, what does an optimal positioning mean? Because I think we all put kids in walking frames and go, this is good. Yeah. But what do we mean by that?
Yeah, so again, for the children with cerebral palsy that were classified within GMS 4s and 5s, sometimes they needed a hip positioner to help de-weight them, or a thoracic support to just give them a bit more support in their trunk, giving them the best position so then they can step and propel, and giving them a successful mobility device or supportive stepping device for them to actually achieve their goals.
I think that's important when you don't have, like, we know children GMS 4 and 5 don't have the same musculature. So you're trying to lever off what they do have to be functional, amongst the fact that these are the kids that have spasticity and dystonia and hypotonia. Like, how do we maximize it? And I think that's, we've had a lot of conversations about how we can maximize mobility. It doesn't always have to be done perfectly. It's function over form, safely, but function over form. And I think sometimes talking about those numbers are really important for sure, but positioning them well so they can, I don't know, feel successful. How many times have I seen, like, I know in my early days of my career, you put kids in a walker and they can't go anywhere. They stay in the one spot. Not because of a lack of desire, but the position wasn't quite right. Was there any hot tips?
Yeah, I think, that's a great point as well, is in terms of positioning them in a walker to be successful. I think we found a lot of the times it was a matter of a few changes, but it just triggered something in the kids' brains to be able to push and propel. And once they got that first bit of success, they just wanted more. And hot tips would always just be take videos and review it, talk to the families, see what they think, and vice versa, ask the families to take photos and videos in terms of how they've been doing at home and getting kids up. I think health technology nowadays lets us do that, and the communication is a lot clearer through photos and videos.
That's true.
And I think, what you're speaking to there is really taking the time to individualize what you're doing for that child, and the results kind of speak for themselves in terms of the improvements that these non-ambulant children are able to make as a result of that.
That's really cool. Well, this seems to be the first data I've seen when it comes to 6-minute walk test for this population. So I guess where to from here? What does this mean? Because this is great data, but what does this mean for clinicians or researchers? What are your thoughts there, Jordan?
Yeah, it's like what you said about knowledge translation before. I think we've got the data, but there's no point doing a clinical audit and keeping it to ourselves. I think it's all about getting it out there. Conferences like AusACPDM lets us talk to researchers and clinicians, but I think it should go beyond that. Get it out to families. If the posters can get out there, and again, what you said before about empowering the families to know that positive change is impossible. We want to get it out there towards families, the information we've got, and hopefully investigating further in terms of what else is possible.
And like looking at different age groups, the fact that you had such a wide age group, what happens if you start this earlier?
That's right. What were you saying? 13 months?
13
is that
months.
right? Up to 24
years.
It's a massive age range, and it's really speaks to the breadth and depth of the data, but then also, you can speak to outcomes across that range.
That's right.
As well, which is very powerful.
The 6-minute walk test is one we're all familiar with.
Oh yes,
6 to be exact. But it's it's a low cost assessment.
Free.
Yeah, that's right. And the thing with a lot of our interventions is we need to be able to measure them. Because if we can't report on the outcomes, we can't show the benefit of anything, whether it's worthwhile or not. If it's not, find something else. But we need to find more outcome measures. And I never thought I'd be someone who'd always say that. Like, we need more outcome measures because, it has to reflect the intervention. It's task specific and really useful. So congratulations on this work and going through all the data so that you could share it with us.
That's a lot of hard work right there, Jordan. Well done.
Thank you.
Bit of a data person.
Yeah.
Numbers.
Yeah.
Love numbers.
Well, hopefully that was really helpful for everyone as well. So remember, this is a poster. So you can go on your app. You can watch the video, which I think has all been uploaded by AusACPDM.
Yep.
Very innovative approaches for posters this year.
It's very exciting.
Lots of different avenues.
Yeah.
So, we'll have a look at those sources, and everyone else, we'll talk to you again really soon. Bye.
Bye.
See ya.